And the third dimension is equity. I mean, when we adopt this universal approach, we need to be very conscious that there are some people that already have a good status of health, already have some good access to healthcare, but others don't. And this gap must be continuously attacked by the public policy on health, because we need to reduce the gaps of mortality, the gaps of disease incidence, no? The gaps of healthcare access, the gaps of quality of care, because if we adopt this completely human right-oriented process, we need to be very conscious that what you provide for society cannot discriminate among those that have money and those that don't have money. That's very clear. No? In this sense, the free access is fundamental. And the other aspect is to disconnect the standard of healthcare to any kind of contributive process. As our new president recognized some days ago, we still have a lot of miserable people. But the state is saying, we will eliminate the miserable, not killing them, but eliminate the miserability conditions in the next 4 years. Because we are adopting measures to do that. And one of the most interesting measures is to connect the new discoveries on oil exploitation directly to the funds to finance social policy. No? So this kind of new approach is very important to connect economy to social policies and not to treat as separate words. I mean, this is economy, we are very well, and this is society, this is very bad, but as different words. No, it's the same word, the same society, it's the same nation. No? So we need to re-embed economy in society. And one of the good ways to do that is through this kind of policy. Yeah. Please, go ahead. So, only to illustrate with more detailed aspects of our process. Brazil is a very big country in terms of territory, no? I think India is 2 million square kilometers. How much is 2 million?
It's 3.3.
How many square kilometers in India? How much? How many?
3 million.
3 million. We have almost 9 million. Right. See? 9 million. And of course, we are not so populated. We have only 194 million. That in Latin America is very, here I talk is not quite small. But anyway, 194 million, a big country. It's the 5th country in population in the world, no? And a lot of disparities in terms of richness, distribution in the territory. We have a south, southeast, quite rich, and the north, northeast, quite poor. But our big cities, we have, as you know, very large, poor population around the cities and so on. So considering the scale, our structural problems are quite similar in terms of dynamics of society as in India we can compare them. In fact, we can compare a lot India, South Africa, and Brazil as 3 dimensions that we could share some understandings about what to do. And we are a federative republic. Huh? So we have the national state, the states or province, as you have here, governments, and then the city governments, as you have here. 27 states and 5,600 municipalities or local governments. In our process, next please. In our process, we define the idea, as I told you, about what would be this human right approach to health, the universalism produced by this approach. And in 1986, 1 year after the end of the dictatorship, we organized a national conference with delegates from all regions, states, representing all the cities through a conference that began with local conference, state conference, national conference. And those delegates established the idea about how could we go ahead in terms to adopt this universal approach to health in 1986. At that conference was very important, the debate between an idea about a system that would be strictly state-owned, I mean a state national health system, versus a public national health system where the private sector would be included. Why? Because when we decide politically that it would be necessary to have a universal health system, the problem is that we had no sufficient state-owned facilities to receive everybody. Because can we imagine to say tomorrow that, hey, everybody here in India, tomorrow we will have a universal health system. Everybody can go to health facilities with no cost and have full care. We did that. And when we did that, we were obliged to say, okay, let's see what we have, everything. State-owned facilities, but state, national state, no? Provincial state, local state, and then let's see what we have in terms of private sector. Charity, a lot of charity hospitals, as we have here in India. They were immediately included in the national health system. For-profit, including for-profit hospitals and services, in the areas where we are obliged to contract them because we didn't have state-owned and charity facilities enough, because it's a problem of scale. So, next please. What we were obliged to conceive, to build, was a unique health system. The name unique in the sense of unitarian, no? Unitarian health system, national health system, combining all kind of providers and facilities in order to make real the concept of universal access. You understand that? So it's totally different in terms of historical background, what happened in Cuba, for instance. No? Because with the Cuban Revolution, the first problem was solved. Almost all doctors left. First problem, solved. No? Next problem was to build the system. And then we have no private sectors, all state-owned. You understand that? So it's completely different. In our case, I say Brazil and India, the complexity is that if we decide politically today that we have a universal health system in India, as in Brazil, it was the case in Brazil, you will be obliged to say what you do with the private sector.